Hi, this is Lindsay again. We're going to move on to our second section of Endocrine Part 1. This is the section on hyperthyroidism, and we're going to touch a little bit on postpartum thyroiditis in this section as well. So this is going to go over the typical presentation of hyperthyroidism, and in this case more specifically of Graves' disease. So let's get started. So hyperthyroidism is defined as the excess secretion of either T3 or T4 by the thyroid gland. Graves' disease is the most common cause of hyperthyroidism, but it can also be caused by excessive iodine supplementation, which can potentiate iodine-induced hyperthyroidism. There is a third condition called toxic nodular goiter, which is progressive, but Graves' disease can actually come and go and may regress in as many as 30% of patients, even without treatment. Graves is the most common form. There is a condition called painless thyroiditis that is the cause in about 10% of people. Typically, this is due to the postpartum is a fluctuation of hormones that occurs postpartum, but it can also be due to lithium or cytokine therapy. 5 to 10% of patients on amiodarone will have a painless thyroiditis. And then subacute thyroiditis is caused by a viral infection and will result in fever and pain. The pathophysiology of hyperthyroidism is related to excessive release of T4 and T3 from the thyroid and into the circulation. And this results in an upregulation of the metabolism of the body. So this will cause symptoms including goiter, high heart rate, blood pressure, and arrhythmias. There will be signs of hypermetabolism such as hyperlipidemia and hyperglycemia. And there will be other symptoms including respiratory muscle weakness, diarrhea, skin changes, psychiatric changes including mania, anxiety, depression, and acute, basically acute mental issues. And then finally there can be ocular manifestations, and these occur only in Graves' disease. So this includes exophthalmos and the initiation of double vision and lid lag. I've included a link to a YouTube video here that shows you what lid lag looks like. If you've never seen it before, it can be pretty interesting to look at. So the degree of severity of the signs and symptoms of hyperthyroidism do not necessarily correlate with how much excess hormone there is being produced. You can think of the signs and symptoms as opposite to hypothyroidism. The skin changes occur because blood flow increases and keratin levels decrease. So this results in sweating and loosening of the nail beds, loosening of the nails from the nail beds, and that's called oncholysis. It can cause hyperpigmentation, hives, vitiligo, alopecia, thin hair, and there's a skin condition that specifically occurs in Graves' disease that's called infiltrative dermopathy, and this affects the skin that's overlying the shins. It causes a raised, hyperpigmented, violaceous, so purplish, orange peel textured papules. The eyes change particularly in Graves' disease due to sympathetic overactivity, but also inflammation of the periorbital muscles, connective tissues, and orbital fat. This results in exophthalmos, which is a protrusion of the eyes that causes double vision, and sometimes can cause corneal ulceration as well because the lids can't close all the way. You can end up with tachyarrhythmias, including atrial fibrillation, and hypertension and cardiomyopathy are also very common. High or normal output heart failure is possible. Those who have hyperthyroidism and atrial fibrillation can return back to normal sinus rhythm within 4 months of correction of the thyroid hormones, but they're still treated with anticoagulation because often the left atrium is enlarged because of the hyperthyroidism, and this can result in thromboembolism. So that's kind of a pearl. So even if the atrial fibrillation goes away with treatment of the thyroid condition, you still want to keep them on their anticoagulants because they're at high risk for clots. Patients may have changes in their cortical bone density, their sex hormones, personality changes, and acute psychosis. So diagnosis of hyperthyroidism is very similar to diagnosis of hypothyroidism. Typically, you're going to measure your TSH and your free T4. Remember that the TSH is the most sensitive marker, and the free T4 only provides additional information about how hyperthyroid the patient kind of is. There are some occasions where only the free T3 is elevated and the free T4 remains normal in mild hyperthyroidism, or if there's a single autonomous thyroid nodule that's present. So we do sometimes check both the free T4 and the free T3 in hyperthyroidism, but again, the TSH is going to be the most sensitive indicator. You may see some measurable changes in the basal metabolic rate, blood pressure, heart rate, psych or neurofunction at the time of diagnosis. So there can be some issues there already present. Other diagnostics can include an EKG, an echocardiogram, or Holter monitor to look for those heart failures and the enlarging size of that right atrium, and then also looking at arrhythmias. And you can do myocardial perfusion studies if you think that the patient is kind of cardiotoxic. And Graves' disease will typically present as a symmetrically enlarged thyroid. They may have a recent onset of ophthalmopathy, and they may have in the presence of moderate to severe hypothyroidism. Typically, patients with Graves' disease do not have a mild disease. If the patient has a thyroid nodule, we work this up with scintigraphy to identify whether or not that nodule is producing the hormone or not. We use a radioactive iodine uptake test, and this is performed when the clinical presentation of hyperthyroidism doesn't exactly match that of Graves, or if there are thyroid nodules in the presence of hyperthyroidism. We cannot use this test in pregnancy, and we have to rely on a clinical diagnosis because obviously we can't irradiate pregnant women. Okay, so there are a lot of differentials with hyperthyroidism, and typically these are differentials that help you to rule out other conditions which can cause the manifestations of hyperthyroidism. So we have to rule out other cardiac arrhythmias. We have to make sure that the pituitary is functioning properly. A lot of patients who are treated for hypothyroidism will become hyperthyroid because they will take too much medication, or they'll change something about their lifestyle, whether that's how they take their thyroid hormone, how much they weigh, etc., and that can really lead to over-medication. Anxiety and depression can mask a hyperthyroidism. Diabetes can certainly coexist with hyperthyroidism and can also kind of mimic some of the symptoms. Malignancy, menopause, pregnancy, carcinoid syndrome, and pheochromocytoma, which are some other endocrine conditions that we will talk about later. So the management of hyperthyroidism is basically related. There's a couple different things we need to worry about. The first thing is symptom reduction. So we use beta blockers primarily for symptom reduction. Typically the ones used are atenolol, propranolol, and metoprolol. You have to be really careful, and we can't give these to patients with asthma. We typically give them to elderly patients who are symptomatic, anyone who has a resting heart rate over 90 beats a minute, or if they have coexisting cardiovascular disease. We sometimes treat patients who are symptomatic in other ways. These drugs basically lower the heart rate, they lower the blood pressure, they reduce the muscle weakness and tremor, and they can improve emotional stability and exercise tolerance for these persons. We also have to be really careful that we manage any other coexisting cardiac problems, such as myocardial ischemia, congestive heart failure, or atrial fibrillation. So we need to decrease the thyroid hormone levels as well. So if the patient has a toxic multinodular goiter, we will either treat with a thyroidectomy or radioactive iodine. Surgery is preferred if there's any element of compressive symptoms, and the surgery can be an ipsilateral lobectomy if it's one single nodule. So a toxic adenoma is the name for that. We also are going to treat these patients with anti-thyroid hormone. There are a couple of medications that we can use. These medications include methimazole, or we can give patients potassium iodide. So let's talk a little bit about Graves' disease in particular, because these are tricky patients. So Graves' disease can be treated 3 different ways. One way is with anti-thyroid hormones, like the ones I just mentioned. We can also treat these patients with radioactive iodine or with surgery. All of these treatments are equally effective. They each have patient-specific risks and benefits, and so you need to discuss with your patient what the best option is for them. You need to educate your patients about specific treatment-related things that they need to know. For example, isolation for radiation treatment, side effects, lab monitoring for anti-thyroid drugs. Any patient that's taking anti-thyroid drugs should have a baseline CBC and liver enzymes. And then because these drugs can cause agranulocytosis and elevated serum transaminases. Patients who are on anti-thyroid hormones should have a differential CBC at any time that they get a febrile illness or a pharyngitis to monitor for agranulocytosis. PTU or polythiuracil is another drug that we can use for these patients, and those patients that take that medication need to be monitored for liver failure. So while we're treating patients with Graves' disease, we can monitor their anti-thyroid oxidase antibodies. If the antibodies decrease to normal, then we can consider tapering off their methimazole after 12 to 18 months. If we go the surgical route and the patient has a thyroidectomy, they should be pre-treated with thyroid medication, and particularly methimazole or beta blockers, until they get to a normal TSH prior to surgery. This reduces the risk of surgical issues. And these patients should be treated with their surgery by an experienced thyroid surgeon. There is a lot of documentation that surgeons that do these thyroid surgeries frequently have much better outcomes than other surgeons who do them only occasionally. After surgery, patients will need to be supplemented with levothyroxine if they've had a total thyroidectomy, and so they're going to need their TSH monitored every 6 to 8 weeks after surgery. As far as follow-up, you're going to keep repeating the TSH and the free T4 about every 4 weeks until you get them to a normal thyroid or a normal TSH level or euthyroid. If they're taking those anti-thyroid drugs, we're going to keep repeating those TSH and free T4 every 3 to 4 months permanently, and then we're going to make sure that we had that baseline CBC to look for agranulocytosis so we can tell whenever they get a febrile illness or pharyngitis if there's been a change in their CBC. And then they can do liver function testing if they're indicated by the particular drug. If we use radioactive iodine to treat the patient, we're going to recheck the TSH at about 6 weeks, then 12 weeks, 6 months, and then yearly after that. Some of these patients who are on radioactive iodine will develop hypothyroidism, and so we need to make sure that we're keeping an eye out for that. About 25 to 90% of drugs who are on an anti-thyroid drug therapy will eventually go into remission with their Graves' disease, but then the symptoms can come back. So it depends on what exactly is causing, their hyperthyroidism. So it depends what exactly caused their hyperthyroidism, how likely they are to go into remission. So we need to just keep a close eye on them every few months to make sure that the level of treatment is appropriate. So there is a complication, similarly to how myxedema coma can occur in hypothyroidism. There is a complication of hyperthyroidism called thyroid storm, and we define this as the presence of hyperthyroidism or thyrotoxicosis and systemic decompensation. There are several criteria that can be used, such as the point scale, and so basically you have these symptoms here, so these in the presence of thyrotoxicosis. So we have some scales like the point scale that can be used to assess these patients and help us decide if they are having a thyroid storm. And if you work in an emergency room, this is something that you need to be aware of. So we're going to do a really quick overview of thyroid conditions in pregnancy. There's a couple pearls I think that'll be really helpful to you as you are thinking about pregnant women and thyroid conditions. So the very first and probably most important thing is that we need to do some preconception counseling to any patient who has a known thyroid condition. We can expect some changes in the thyroid function as a result of pregnancy, and we need our patients to be working with us to ensure that we're meeting their needs. So we know that in a patient who has established hypothyroidism, their levothyroxine needs will increase by up to 50%. I worked with an endocrinologist for a while who was sure that she could tell you um, if the mother was carrying a boy or a girl based on how much their levothyroxine demand increased. And I think she said that when women were carrying girls, their levothyroxine needs were a lot higher than when they were carrying boys, but don't hold me to that. So we hold our we want our hypothyroid women who are pregnant to have a much stricter normal range. So in the first trimester, the TSH needs to be under 2.5, and it needs to be under 3 in their second and third trimester. Uncontrolled hypothyroidism and hyperthyroidism are both very dangerous to the mother and to the developing fetus during pregnancy. Hypothyroidism can result in miscarriage, depression, gestational hypertension, placental abruption, and a higher rate of C-section due to non-reassuring heart tones in the fetus. They could also result in postpartum hemorrhage, perinatal morbidity and mortality, and newborn neuropsychological impairment. We are pretty careful about hyperthyroidism as well, because this can result in miscarriage, preeclampsia, premature labor, heart failure, anxiety, fetal growth restriction, and thyroid storm in the mother, the fetus, or the newborn. So as I mentioned, we have to control the TSH very tightly during pregnancy, especially in the first trimester. The fetus cannot make its own thyroid hormones until 12 weeks of age, or 12 weeks of gestation, which is why we keep the range even tighter in the first trimester than we do in the second and third. We can expect that the need of the pregnant woman for levothyroxine will continue to increase until around 20 weeks gestation, when the HCG levels peak. And that's because HCG hormone increases the release of thyroid hormone binding globulin, which reduces the amount of free T3 and T4 available in the bloodstream. Fortunately, levothyroxine is very safe in pregnancy and lactation, so you can assure women that not only is it very safe, but it is the absolute best treatment to keep that baby safe in pregnancy. We do need to be aware that there is a small subset of hypothyroid patients who actually had a burned out version of Graves' disease. So they had Graves' disease before, and it's burned itself out. It's what we call it. They've gone hypothyroidism because their thyroid has basically attacked itself to the point that it's stopped working entirely. If the patient has a burned out Graves' disease, they are likely to still have those circulating TSH receptor antibodies, and this can actually affect the fetus's thyroid and cause a fetal Graves' disease. So we test these women during the third trimester, and then we also make sure that they have a very controlled delivery environment with pediatric endocrinology attendants, so that we can manage potential neonatal Graves' disease if the baby's born with Graves' disease. So, subclinical hypothyroidism, the only time we really treat this is in pregnancy. Women with an elevated TSH but normal free T4 will have subclinical hypothyroidism. The women with women with a normal, so I want to make sure I say this right. Women with a high TSH but normal free T4 have subclinical hypothyroidism. If their TSH is over 10, they require treatment. Women with a normal TSH and low free T4 have maternal hypothyroxanemia. This does not require thyroid replacement. Women with recurrent miscarriage, subclinical hypothyroidism, and positive thyroid peroxidase antibodies can be treated with levothyroxine as part of preconception and prenatal care. So we can treat subclinical hypothyroidism if the patient has positive antibodies and they've had miscarriage before, because this might be contributing to their recurrent miscarriage. So, hyperthyroidism in pregnancy. So there is a physiologic, so normally occurring transient hyperthyroidism that happens around the end of the first trimester, usually between weeks 12 and 18. As I told you, that's because of those stimulating effects of HCG. This happens more commonly in patients with hyperemesis gravidarum because they have very high HCG levels. Those women do not need treatment. Women with Graves' disease, as we talked about before, can have thyroid antibodies which attack the fetus's thyroid, and so they need to be monitored for that birth as well. And then we can predict that Graves' disease may relapse in the postpartum period, so we need to be very careful that we monitor our postpartum women with history of Graves' disease with a TSH at least in the 2 to 6 week postpartum range, which fortunately falls within that postpartum visit range. So if your patient has a hyperthyroidism, you do want to check them in that time period. We cannot use radioactive iodine in hyperthyroidism. It's absolutely contraindicated. Both PTU and carbimazole are contraindicated in the first trimester, and they can cause birth defects. But if we have to treat a woman for hyperthyroidism, we use PTU because most of the side effects or the defects that occur in the fetus are mild and easily correctable. So things like cleft palate, cleft lip defects. Neither drug is absolutely contraindicated, but we need to be careful to use the lowest possible dose. I would pretty much not be prescribing these medications for pregnant women. I think if you have a pregnant woman with overt hyperthyroidism who needs treatment, you need to get her into an endocrinologist ASAP. Hopefully she already has one. Propranolol can be used for symptom management for short periods of time in women who are or in pretty much anybody who has hyperthyroidism, but pregnant women as well who are waiting for their anti-thyroid drugs to take effect, because the symptom management, we don't use it long term because it can have some effects on fetal growth. It can slow down fetal growth. In a woman who has hydatidiform mole, this can produce a very severe hyperthyroidism, and that can require treatment prior to having their section D and C procedure. So if a woman has hydatidiform mole and hyperthyroidism, they should be treated before surgery. Any patient who has hyperthyroidism in pregnancy should be referred to an endocrinologist and OBGYN as soon as possible. They need to be considered high risk in pregnancy, and they need to deliver in a hospital with a pediatrician and an endocrinology consultant available. Any patient who's on anti-thyroid medication during pregnancy should be monitored with thyroid function tests every 3 to 4 weeks. And we need to be really careful when we're monitoring our postpartum patients to make sure that they have postpartum thyroiditis, so a postpartum hyperthyroidism, as opposed to a postpartum relapse of Graves' disease, because the treatment will be different for the two conditions. If you are breastfeeding and you have hyperthyroidism, both those medications, the PTU and carbimazole, are safe for lactation, so you can take either of those. So I know that was a lot. I do want to just really quickly talk about postpartum thyroiditis. This is going to affect about 6 to 7% of postpartum women. So they will have most of them will have a temporary hypothyroidism. 50 to 70% of the women who get it will recover within a year, and 30 to 50% will result in permanent hypothyroidism after a year. This is an autoimmune inflammation that occurs within the first 2 to 3 months postpartum. It's linked to high levels of thyroid peroxidase antibodies both during and after pregnancy, and it's also linked with mood disorders such as depression. If a patient has concurrent mood disorders, that in conjunction with normal postpartum changes can make it really hard to tell if the patient is hypothyroid. So for example, it's really very common for a patient to have fatigue, weight changes, and irritability when they're sleeping in 2-hour chunks and they have just had a baby and are losing weight. So it can be really hard to pick out. You need to keep this in the back of your mind to make sure that you're looking at the woman who's just experiencing the things a little bit more strongly than you would have predicted based on her postpartum condition. So There's also a condition called lymphocytic hypophysitis. So your pituitary sits in the hypophysis. So you get a lymphocytic inflammation of your hypophysis. And this is another condition that occurs postpartum that can mimic postpartum thyroiditis. However, these patients will have normal TSH levels, but low free T3 and T4 levels. So this is a problem with the pituitary and is a secondary form of thyroiditis. So these are not, it's not a thyroiditis, it's a secondary form of hypothyroidism related to pituitary inflammation. So if you see that, which you probably will not, you need to refer them to endocrinology, and they need to have other pituitary and endocrine testing. If you have a patient in the postpartum phase who is hyperthyroid, they need to go to endocrinology to be fully evaluated for Graves' disease. So again, I know this was a lot of information, and especially the pregnancy. When you're dealing with pregnancy and those other conditions, it can be a little bit overwhelming as the provider. So basically, I think as the primary care, your focus needs to be what is normal, what is not normal, and when can I treat this in the office versus when do I need to send this patient out. I don't think you're going to see a lot of questions about these on your board exams. The thing that you need to remember about pregnancy is just that you need to keep the patient as euthyroid as possible, and they need to be monitored more frequently because the mother's thyroid status, especially in the first trimester, will affect the fetus's growth and development. So again, if you have any questions, please post them to the discussion board. I'm going to put one more part of this lecture up, which is how to deal with thyroid nodules and thyroid cancer.